So what all have we learned about this weekend? Have we looked at neurotransmitters? Yeah, so behavior. Have we looked at frontal lobe, facial masking? Yes, we've looked at all of that. So the first thing I'm going to do is talk about observation. So when you talk about observation, are y'all going? Okay. When you talk about observation, you obviously want to look at their gait. And are they a shuffling gait, like a Parkinsonian gait? Do they have a foot drop, like with some nerve damage? Is it a wide-based gait, like with a cerebellar problem? Is it a waddling gait, like with a primary muscle disease where their proximal hips are weak? Do they have a body or head-forward posturing with a tremor along with it? Do they have difficulty turning? When they walk, do they not have any arm swing on one side? Can they not dual task, meaning, hey, I want you to think about numbers backwards from 100 down to a 0 while you walk? And then we look at things like, do you have fasciculations? Do you have a tremor? Do you have some sort of like truncal sway? And so we look at these things and we say that's abnormal motoricity. And then we try to figure out what might be causing it. So from the second they walk into the exam room, we're looking for those things. What does their face look like? What does their posture look like? Are they dystonic? Is their arms postured? Are their legs wide apart, close together? Are they stiff? Those are all things that are important to look at. So we go up and we take a look at the face. And one of the things we want to look at with the face is it symmetric? And nobody's face is completely symmetric. One side will look a little bit different than the other. And they've even done some studies that real true beauty, really, one of the things that sort of defines true beauty is with one part of your face, one half is really symmetric with the other half. It helps with beauty. But we look at things like, okay, hair or no hair. Well, if there's no hair and it's in a weird pattern, or if there's a certain type of hair loss and it's escalated very rapidly, then we worry about autoimmune conditions that might have created hair loss, especially in females. The other thing we look at is, okay, is there any tilt in the head? Is there any dystonia? So is it tilted and rotated, or is it just rotated? That can mean a lot in regards to many regions of the brain. But again, just giving basic observations right now. And then as we look at things, we look at the eyes. Are the eyes level? Is there atropia, meaning I can see the eye misalignment? Is there a hypertropia? So give me two glasses that are obviously being used. These are perfect. Here. So if this is my eyeballs, is there a hypertropia, or a hypotropia, or an exotropia, or an esotropia? So we're not doing a cranial nerve exam yet, we're just saying observing. And then we observe, is there one pupil bigger than the other? These are just basic exam findings. So I'm starting from the top and working my way down. The next thing we want to look at is, are the eyes doing a little bit of abnormal blepharal movement? You know, some people will have straight out blepharospasms where when they close their eyes, they'll get stuck, or their eyes they'll clench in. Or we may see just a little bit of blepharotwitch, where you see the eyelids kind of do this, or when you shut the eyes, you see them bounce around a little bit. Close your eyes. Just a tad bit. I don't know if you guys can see it, it's not bad. It's the lean in. And then we want to look for other things like entropions and ectropions. We want to look for the lids turning in, the lids turning out, or if there's any sunsetting, or if the eyelids are retracted. You see this a lot in Parkinsonian patients. They'll lean forward a little bit and their eyes may retract a little bit. Not their eyeballs, but the lids. And then we want to kind of tilt the head back some and look at the eyeball and see if there's any proptosis, where one eye is bulging out compared to the other. So you pretty much just looked at the eyes and said, okay, what is their position? What are the lids doing? What is the head doing? What position is the head in? What's going on with the hair? Is there any weird losses? I mean, if it's male pattern baldness, it's male pattern baldness. Don't get freaked out about that. I mean, Take a look-ski, okay? And then you look at things like facial tone. So does it look like one side of your face is not working? Your mouth is asymmetric? Or you have a deviation in anything, like a deviated nose, which could be a deviated septum, which could change breathing, which could change oxygenation, and could change the brain. We talked about that earlier. And then when we look at this, we're like, okay, are the lips pursed? Is the mouth open? You know, what does their faces look like? So we've gone through and we've looked at those things. Now, again, look at the outer ear. Is there any drainage? Look at the eye. Is there any drainage? Look at the nose. Is there any drainage? And then we can move down to the neck, and some people have lymph nodes that are large enough that you can actually see. We have deep chain, cervical chain. We have posterior suboccipital chain. We have supraclaviculars. These can all be enlarged. And then we, of course, want to look at the thyroid. And if there's a thyroiditis that's enlarged enough, we ask if it's painful or painless to determine what it might be related to. Things like Hashimoto's may be painless, but infection or trauma may be painful thyroiditis. Or there might be a goiter. So you kind of find the Adam's apple, if there is one. Did you get yours shaved off? Okay, no you didn't. Good. And down here there may be like almost looks like an extra fat roll. And you can go in there and you can palpate that. Look for thyroglossal cysts, the whole 9 yards. Then look at the skin, make sure that there's no lesions. And if there is a bunch of lesions, what kind? Is it, you know, some sort of eczema? Is it plaquing? Is it ulcerated? Does it look like staph? What type of skin lesion might it be? That would have everything to do with your immune system, maybe your detoxification system, maybe exposure to certain organisms, what's going on. Is there any crusty, sort of honey-colored lesions on the skin or the nose? That could be impetigo. All right? So those are just some basic things that we're observing on the head. And then we want to observe for range of motion of the neck, and we don't necessarily have to go through and teach you how to use a goniometer or inclinometers, but can you bend forward? Can you bend backwards? Can you do left and right lateral bending and rotation? And one of the things I always like to ask about is when you go into forward flexion, does it create any shocking pain down the spine? One of the ways to perpetuate that is if they're like, yeah, I don't know, tuck the chin down. Now, as you go forward in flexion, what will tend to happen is, in order to avoid a Lhermitte's response, the flexion will go out of the neck and they'll start to flex in the thoracic spine or even at the waist. So if you lock them in here, get their chin and tuck it down and pull this way. That will initiate a Lhermitte sign because you're stopping the flexion in the thoracic spine, you're locking that in, and then when you tuck that chin in, it takes the atlanto-occipital joints and puts lots of flexion in there. And if there is sort of compression on the cord, it will put more torque or more pressure on it, and you'll feel it. Typically as a jolt down into the limbs or in the body. So you want to make sure of that. Now, with basic extension, you want to say, okay, look, now the neural foramina are narrowing. So is there any jolting down the arms, like with nerve root pathology? And the other thing you want to say is, whenever we do this, is there any dizziness? Because with benign paroxysmal positional vertigo of the posterior canals, which is the most common, even as you lean your head back, you may start to get vertigo. And it's typically an upbeat torsional vertigo. And you can just simply hold the eyelids open right here and just see if there's any vertigo. Now, if they start to get a little bit of lightheadedness, if you take the head and extend it back, kind of stabilize here, and then push forward, the vertebral arteries, as they come up, they will do this. They will run up, loop this way, and then go back that way. So if I stretch it like this, you may get a little bit of vertebral artery insufficiency. So again, when somebody is coming back, hold on the sternum, and you can push forward, and it will take that and stretch it. And a lot of times, they'll start to get a little bit of consciousness change. So some things you can do is just say, hey, just talk to them. Say, hey, can you answer my questions? How do you feel? And they may start to slur their speech, or if they start to get ischemic or hypoxic, they may have some issues with that. So that's what I'm looking at with extension. If I do think I have nerve root damage in one arm, then I can bring the head over, and then I can apply some downward pressure in different positions and try to see if there is a positive foraminal compression test. All right? So that's a good start. Now there may be things, obviously, that are missing, or there may be some things that you want to add in, but that's a good start on just taking a look at the face, the skin, the hair, the head, the neck, and saying, is there thyroid problems? Is there lymph node problems? Is there eye problems? Ocular alignment problems? Is there lid movement? Does their skin look good? Is there any drainage out of their ears? And then, of course, you would do your physical exam and look in the ears, look in the mouth, and look in the eyes. You would do that as this. I'm not going to go through that on this section. I'm just giving you some observation. Now, the next thing you want to look at is look at the posturing of the shoulders and see if there's any inward rotation of the shoulder. See if there's any flexed posturing. See if they have a cortical fist, thumb tucked in, fingers over like this, and it brought in close to the body. We see that a lot with stroke. See if there's any tremors where it's a flap. See if you can calculate the hertz of the tremor. Parkinsonian hertz will be different than rubral versus red, white, red, black, different types of tremors that are mesencephalic. So as you go through, there may be different types of tremors, but you want to calculate how many times does it move in 1 second. In 1 second. Is it a resting tremor? Is it a tremor just during movement? And then look at their body, and of course typically you might have less clothing on, so just use your imaginations on this. Not too much, but some, okay? And determine, is there movement? Is it distal? Is it proximal? And is there any fasciculations? And a fasciculation is where the muscle, the motor unit, which is made out of multiple fibrils, is it spontaneously firing? And if it is it happening in one area or multiple areas? And benign fasciculations will typically tend to happen in one area repeatedly. But a pathological fasciculation may happen in multiple areas, and it may even start to spread up into the bulbar region or the cranial nerve region or in the face. So we look at that, we've looked at the posturing, and now we really want to observe for muscle loss. So let's go through these patterns. So there's frank atrophy, where you can just look at it and say, man, that muscle is gone. So with primary muscle disease, that means it's a muscle disease that's not related to something else. Like, could you have a muscle disease related to radiculopathy? Yes, if it denervates, the muscle will die. That's secondary to something else. But a primary muscle disease, a lot of these are genetic, questionably autoimmune, and they like to start in proximal limbs. So fascio-scapulo-humeral dystrophy. So the neck will probably be intact, but then everything in the shoulder girdle will start to lose tone. And then you'll lose a little bit of paraspinal tone, but then you go down a little bit lower, and maybe they preserve some of this down here. But then they may start to lose some muscle in the girdle. Now there's another muscle disease called limb-girdle dystrophy. There's another one called Duchenne's. There's lots of different types of muscle diseases, but the point is this. They don't start in the hands, they start proximal. And it doesn't involve one nerve root. It involves multiple nerve roots. And it doesn't involve the plexus. And it doesn't involve the cord. And there's no sensory loss. So if you have proximal wasting and damage with no sensory loss that's slowly and progressive, and your MRIs are clean for like radiculopathy or myelopathy, then you might want to consider a muscle disease. And if there is a muscle disease, an electromyographic examination, like an EMG, is a good study. A muscle biopsy and then muscle enzymes might be good as well. So you're going to see if it's breaking down. If it is breaking down, what type of breakdown is it? And then the EMG will tell you what stage or phase of chronicity it may be in. Now that differs significantly from ventral horn cell disease. Ventral horn cell disease, like progressive muscular atrophies or ALS, now instead of the atrophy starting proximally, it will start distally. So now the hands start to go away, and they start to atrophy, and they start to get weak. And it may start on one side, but then it goes to the other, and then it may progress up to the forearm or the elbow, but the shoulders may be preserved a little bit more, at least early on. Now later on, their bulbar system may get weak, their respiration may get weak, but there's no sensory loss. Again, with ventral horn cell disease, that's motor, there's not much sensory loss. With primary muscle disease, that is an end organ muscle issue, there's no sensory loss. The thing that goes hand in hand with the ventral horn cell disease is that in the lower extremities they get spastic or tight. So if somebody comes in and they have upper motor findings in the arms and lower motor findings in the legs, sorry, I said that backwards. If they have lower motor findings in the arms and upper motor findings in the legs, that could be ALS. Now let's just real quick define what upper and lower motor is. Lower motor findings is like peripheral nerve damage, compression, anything from the ventral horn cell out. So those are lower motor findings. So if you have lower motor findings in the arms and then upper motor findings in the legs. Now, upper motor is things like hyperreflexiveness, spasticity, Babinski, or upgoing toes. Those will be things that you'll see in the legs. So what else could look like that? The answer is cervical myelopathy. So there is a myopathy, which is M-Y-O, myopathy, which is a muscle disease. And then there's myelo, which is M-Y, okay, myelo. So there's myelopathy, which is disease process of the cord. Now, myelo may also refer to bone marrow. Just throwing out some terms there. So, as we look at him, we say, is there atrophy proximally or is there atrophy distally? Is it bilaterally? So, proximal versus distal, left versus right, or bilateral. That's where we're at. If it's just on one side, we have to ask ourselves, is this progressing into a systemic issue like ALS, or is this just a nerve root lesion that's creating damage in multiple areas? So I'll go through those and how you break those down as well. So far, we have primary muscle disease, no sensory loss. And we have ventral horn cell disease, no sensory loss. Up here, primary muscle disease. Down here, ventral horn cell disease. Everybody got that? Good. Now the other thing we have that can cause some weakness is neuromuscular junction disease, like a Lambert Eaton or myasthenia gravis. Myasthenia gravis stays up here. It's post-synaptic. And then Lambert Eaton is typically more presynaptic, and it happens in the whole body. Now these people will get weak, probably not get as much atrophy, but they get significant weakness with exertion. Weakness with exertion. So like in the face, you can have them squinch their face up or do repetitive nerve stim, which is activation over and over and over. And then the quanta of neurotransmitter that hits the postsynaptic cleft, it doesn't do as well because there's antibodies that are actually blocking the receptor of some type. So those are truly autoimmune diseases typically. And most autoimmune diseases have a genetic background in there somewhere. Okay? So we've got, do you have weakness that is because of the neuromuscular junction? Do you have weakness because of primary muscle disease? Do you have weakness because of ventral horn cell disease? Or do you have weakness now because of nerve root damage plexus damage or individual entrapment. So you can see how it's not quite as simple as you think. So now you go and you look at the hand and you're like, okay, everything that I think has atrophy, I like to feel it. So when you're looking at the hand, I'll put my finger back here and then one here and squeeze, and then here and here and squeeze, and just feel for tone. And I always compare it to the other side. Before a muscle gets significant atrophy, it will start to feel fluffy, or the resistance of it will not be any good. So you go through and you're like, man, that feels awfully soft. And then you compare that to other areas and you're like, they're not as soft here, they're not as soft here, this area is really soft. And the hand is an area that typically should have pretty good muscle tone in it because you use your hands daily. So, here's the hand. This thenar region is median nerve, and this hypothenar is ulnar nerve. As you turn this way and you look at the first dorsal web space, you should be able to get it like this and push together and see a rise in that area. When you do see that, the first dorsal is intact. That's related to ulnar nerve. So the first dorsal makes the finger go this way and this go this way. So if you go like this, bring these fingers down, and you make a U, bring your fingers apart like this, together, apart. It makes a U. That's ulnar nerve. Is that simple enough for you? Turn the hand down this way, bring this up. Don't let me push this down. That's median nerve. Now there's another branch of the median nerve that comes off up here and comes off. It's called the anterior interosseous nerve. It has no sensory component to it. So it's hard to test. Here's the best way to test it. Curl the tip of the thumb in. Don't let me pull. So, leave your fingers like that. Leave your fingers like that. Leave your finger like that and curl it in. Here's some instructions. Do not let me move your hand in any direction. This will be on video. Push right here. Ulnar nerve. Don't let me pull here. Forearm flexors. C8. Don't let me push your thumb down. Median nerve. Anterior interosseous nerve. Don't let me push. This way or this way. That's C7. Now the hand is just like this, okay? So it's in this position. Now don't let me turn it either way. Checking supination, checking pronation. Do you see how I just did that real quick? Don't let me move your hand in any direction. Here, 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 there, push, push. Did the whole thing. How long did that take? 10 seconds. Maybe. Now, ready? 8 and T1. 7 and 8. 6 and 7. 5 and 6. 5. That's the nerve roots. 5. 5 and 6. The first half of the forearm, 6 and 7. 7 and 8. 8, T1. So anytime I break down the ulnar nerve down here, remember it's comprised of what? 8 and 1. So if both the median nerve and the ulnar nerve are involved, and I turn the hand over and spread them apart, and you start checking these little intrinsics of the hands, that's highly T1. You come over here and you're like, wow, the ulnar nerve and the median nerve is weak. Is it the beginning of ventral horn cell disease? Or is it a lower cervical root lesion? Or is it an inferior lower plexus lesion? What is the real quick way to go through ventral horn cell disease versus nerve root damage? Sensory loss. With sensory-related nerve root damage making the hand weak, there is typically a dermatomal component. Now, we don't live in a world where every single thing about a lower motor neuron lesion exists perfectly, like it does when you were taught in school. The motor stuff may not be as profound as the sensory stuff because sensory fibers are more prone to be damaged with compression. But we've gone through and we've looked at the atrophy, we've tested the arm. I'm addressing a man on video. No messages. I can just see my inbox now. We look at the forearm, there's no fasciculations, there's no atrophy here. So, good muscles that are switch muscles, like C7 and 8. Flexor pollicis, longus, the brevis is in the hand. 6 and 7, the pronator muscle. So pronation is like this, supination is like you're holding a bowl, right? So try to turn your hand over. I already tested that just when he had his hand in place. As the arm is down like this, don't let me push. This is teres major, pushing out like this. That's what? Teres minor. It's major if you pray. That's bringing the hands together. It's minor when you take it apart. That's where the elbows end. As soon as you abduct, now you have different muscle groups. So we will get to the point to where you'll see this, and you'll see this, and then you'll see this. And then you're pretty much done with the upper extremities. So far, we've looked at face, we've looked at posture, we've looked at ambulation, we've looked at skin, we've looked at thyroid, we've looked at eye position. We've looked at everything. Is he losing the outer third of his brow? Does he have, one side of his face that doesn't have the ability to move? Can he not shut one lid? Does he have just weakness on this side of the face down here, or is it up here and here? If it's just down here, maybe contralateral stroke. If it's here and here, maybe we have a facial paresis, which used to be known as a Bell's palsy. And then we look, is the head tilted? Is there dystonia? Which way is the head rotated and which way is it tilted? Is it tilted and is it spread into the limb? Is he okay and is he spastic like he had a stroke? Is it in just the arm and the leg, which we'll get to the legs in just a second? All right. As we look in the hand, is there atrophy in just one nerve cutaneous distribution, like just the median? Because maybe carpal tunnel, or because of pronator teres. Or it's hard to get a nerve root that just damages the median nerve because there's multiple nerve roots that go to it. Now the ones that activate the median nerve that are up here, like with pronator, those are higher up nerve roots than in the hand, which are lower nerve roots. So our goal is to say this. We have somebody that comes in with weakness, and we are observing them. If what we observe, is it related to ventral horn cell, neuromuscular junction, muscle, root, plexus, or an individual peripheral nerve. On my Facebook page, I put a chart that outlines all the peripheral nerve areas and lesions. So you can correlate that with this observation section. We observe with our hands by feeling, and then we look and say, oh my goodness. Most people that have denervation from nerve damage, they don't get fasciculations. Fasciculations happen very commonly in ventral horn cell disease, more than just denervation because a nerve is compressed. So we observed all this, the bicep and the tricep. So if we lose everything in the forearm, and then most of the back of the arm, but the front of the arm and the shoulder is preserved, that's 7. Okay? If it's just the radial nerve, it will just hit the back of the arm and we'll start to get a finger drop. And these middle fingers will drop first, and then typically these guys will start to drop second. And then we may get a wrist drop. And the radial nerve runs through the supinator region, or the arcade of Froge, and then it runs through the posterior part of the humerus, the spiral groove. So we've got the radial tunnel, the spiral groove, and then it runs underneath in the axillary region and the posterior part of the shoulder, and then it runs along the posterior cord of the plexus up to the nerve roots that innervate it. The median nerve runs through the Struthers region back here by the elbow, and you can calcify Struthers and compress it here, or it can get compressed in the pronator region. Well, how do you know? The muscle that entraps a nerve is preserved. So you just do this. Remember when I went back and checked pronation and supination? If pronation is weak, and it's all median nerve patterned, which I'll show you more about that in a minute, then I might have to start thinking pronator teres problems. Come up here into what's called the divot of death for the electromyographer. You don't stick any needles in here, because there's lots of blood and nerves and all kinds of that, blood vessels and stuff like that. It's right here. It's the V of the heads of your pronator muscle. Put that in there, press and pull down, and then just see if you get any numbness, tingling, or neurosensory changes.
Not yet.
Huh?
Not yet.
Okay. Now typically, like I've had a few of these. A good obvious example was I had a lady that used a power drill all day long. So she held that down, and when she turned it on, in order to resist the way the drill moved, she had to push in pronation. So her pronators looked like Popeye the Sailor Man. But the rest of her didn't. And there was clear entrapment of the median nerve in that area. So we have the wrist as well. The median nerve can get entrapped here. The ulnar nerve can get entrapped here. In the pisiform hamate region, there's 4 patterns. So the median nerve, I can draw on you, correct? Sure. The median nerve comes through here, and then we have a deep branch, and then we have a superficial branch. So, sensation to the 5th digit and half of the 4th, and then as it comes up and goes around this way, it innervates my hypothenar, and it comes across and innervates my first dorsal. This is the ulnar nerve. This is the ulnar nerve. If I said it backwards, I apologize. So if you have a type 1 pattern, type 1, it's here in the palm somewhere. And the only thing weak is this muscle. Push this up. This is the first dorsal. But the hypothenar is spared. The abductor digiti minimi is spared. If it's a type 2 lesion, now it's on the deep motor branch, and it's just right here, but it's proximal now to where the abductor digiti minimi is. So now the abductor digiti minimi and the first dorsal are weak, but there's still no sensory changes. If it's type 3, this is your classic Guillain Canal. So now we have sensory loss in the 5th, half the 4th, weakness here, and weakness here. And if it's type 4, it's just compression of the superficial only, and now all the motor stuff is preserved, but the sensory findings are lost. That's at the wrist for the ulnar nerve. Now, anything that happens at the wrist does the following. The tips of the fingers, the digital branches, are more involved than the palmar branches because of this. There are recurrent branches that don't go through the tunnels that innervate everything from basically here to just a little bit proximal to the actual wrist. So if you have lost sensation in the 5th digit and you have lost sensation the exact same amount in the palm, but you haven't lost any sensation up here, the lesion is probably in the elbow. But if you have lost sensation in just the digit but not the palm, you have to say, is it a type 4 lesion or a type 3 lesion of the ulnar nerve distally? Median nerve is the same way. So I always compare this digit to see what the ulnar nerve looks like compared to the median nerve. And they're like, oh, you know, I clearly can't feel it in this digit. And then I'm like, okay, well, does this feel the same as that? They're like, no. Which one do you feel less? I feel the thumb a lot less than I do the palm. Then you can do your Tinels, and Tinels are not really good tests. So you don't want to go in there with your reflex hammer and go bang, bang, anybody will be positive. If you just barely tap, and these are setting off big, big responses, then that is more of a positive test. So now I've said, is it ulnar distal? Is it ulnar proximal? And if it's ulnar down here, which pattern is it? 1, 2, 3, or 4? Now the ulnar nerve down here can be entrapped right about here, which is the retrocondylar groove. Or it can be entrapped a little bit more distal, which is the cubital tunnel. So if you have lost the flexor carpi ulnaris and all of the other ulnar nerve muscles, it's entrapment in the retrocondylar groove because the cubital tunnel is made out of, in part, the flexor carpi ulnaris. So here's how you activate it. Slightly flex, deviate, now hold that, and you're pushing, and now it doesn't work. If that's weak, it's here in the retrocondylar groove. Take the arm, put tension on the nerve and give it little taps, and you'll be able to find the exact place. If it's at the actual tunnel, you can come in here and compress, and now that is the actual place. So, there's 3 major nerves: radial, median, and ulnar, with 3 major sites of entrapment. The ulnar nerve is 1, 2, 3. The median nerve is wrist, 1, pronator 2, Struthers 3. The radial nerve is radial tunnel 1, spiral groove 2, posterior musculature compartment, triangular, quadrangular, and lower armpit, that's 3. 3 major nerves, 3 major areas. To make it simple, if something happens in the wrist, fingers more involved than palms. If something's happening in the elbow, fingers and palm are the same. If something's happening up in the nerve root, the sensory distribution at least will go finger, assuming the nerve root covers the hand, finger, palm, and then forearm. So if you can see those patterns, you can start to now determine, is this an individual cutaneous nerve? Where is it? Is this a nerve root? Where is it? Is it 6, like a 6-shooter? Is it 8 or T1 down here? 8, 1. Is it 7, which is back of the arm, sliver down the middle? 7 innervates the periosteum of the bones, which makes the whole arm hurt with a C7 radiculopathy. And then, of course, we got 6, which I just showed you, 5, and then 4, and then all the way up to 2, and then we've got V1, which separates right about here. The upper cervical goes on the back of the head, and then the trigeminal system starts on the front of the head and then goes down in the distribution all the way around to here. So I'm observing this patient. I've observed their head, their gait, their skin, their throat, their eyes, their facial symmetry. Do they have any spontaneous quivering of the muscle like a fasciculation? Is there any movement that crosses a joint like a tremor? And then I've looked at muscle atrophy, and I've looked at the pattern of atrophy to say this. Is it an upper plexus lesion, which would be all shoulder? Is it a lower plexus lesion, which would be all hand? If it's all hand, is it ventral horn cell disease, or is it lower root lesion or lower or inferior plexus lesion? Well, all plexus lesions and all root lesions have sensory loss. Ventral horn cell disease does not. So those are things to consider. Now, if you have an atrophied hand and you have tightness in the legs and there's a lot of sensory loss and there's an entire sensory loss on one side of the body, that could be spinal cord damage, and the level that it starts at is where the root signs are. That is about as much neurology as you're going to ever need to know on the observation of this part. Now you observe the trunk. Do they have wasp wasting? So typically there should be a V shape, but if they're really narrow and losing everything up here, like with a primary muscle disease, and they're narrow up here, but now they've widened out down here, and now they're losing their thighs and buttock region and girdle, another sign of muscle disease. So as we look at gait, and then we look at lower extremities, we have to realize that now we divide this into two compartments. We have the front compartment, which is 2, 3, and 4, and the thighs. So we always divide the leg in half, right here, down the middle, just like the pleat. And then we think, okay, what spirals around? And then what is circular? So we have pudendal, lower sacral roots, and then we have 2, 3, 4 down to the inner arch. So does the sensory loss cross the midline of the thigh, and does it cross the knee? If it's just out here on the side, it's meralgia paresthetica, or the lateral femoral cutaneous. If it crosses in a spiral shape, it's dermatomal. The higher up it is, the higher up it is in the lumbar region. If it goes over the belt line, it's probably in the thoracic distribution. 5 goes down the side, like the stripe on tuxedo pants. And then it may go down on the top of the foot, in between the webbing of the toes, and then there may be one sliver on the bottom. And then the back of your leg is divided into 2 halves. S1 out here to the outside of the leg, and S2 on the inside down to the middle part of the leg. And then as it gets closer to the rectum, it's 3, 4, whoop, toilet bowl, sort of 2, 3, 4, pudendal we go. It's just right there, all the way up. And those are the more nerve roots that make pudendal. And the sensory pattern, which can be, of course, damaged with cauda equina syndrome. Those nerve roots run in the midline, and most disc herniations go lateral because there's a posterior longitudinal ligament, so it herniates around that. So as we observe this, we have to say, are you losing it in just a thigh, which could be an upper root lesion? Are your legs spastic or stiff, which could be upper motor pathology with a stroke, with a cord lesion, or even with ventral horn cell damage? We go down, we look at the feet, and we say, is there any fungus on the feet? We look at the color, is it very red? Or is it swollen and edematous? And is there purple staining, like with venous insufficiency? Or are you just retaining fluid? Like if your albumin levels are low because of SIBO and it eats up all your total proteins, and now you have edema because albumin keeps things in your bloodstream and it keeps it from going into your interstitial space. And then we do our capillary refill on all of our distal portions. Is it cold and warm? And he's a little bit cold here. Should you have some coffee? Yeah, there's your coffee. So it's cold here, warm here. And so we go down and we compare temperature proximal to distal. We look at capillary refill. Does it happen within 3 to 5 seconds? We look at the nail beds and see if they're splintering, cracking. Are they puffing up? Are they doming? What are they doing? Then we go down to the feet. Most of your fungi will grow on your toenails before your hands because of the stasis down lower just over gravity. So when we look at that, we've looked at the arms, we've looked at the legs, we've felt for tone, we've looked for capillary refill, we've felt for temperature changes, we've watched their gait. Are they a wide-based gait like a cerebellar person? And are they sort of drunk walking? Are they scissor gating? Are they spastic and circumduction gating like with a stroke? Are they slappage gating? And if it's on one side, it could be nerve damage. If it's on both, do they have a hereditary motor sensory neuropathy? So most neuropathies start out with sensory symptoms first, then progress to motor, unless it's related to vascular, inflammatory, or it's hereditary. So if your distal leg is shrinking, your arches are getting high, and you're getting hammer toes, that's a hereditary condition typically. And hereditary things that cause peripheral nerve damage, the motor findings are much faster escalating than the sensory findings. So now they get things like a Charcot-Marie tooth where the peroneal distribution gets very weak, or they get what looks like a peg leg distal to the thigh. And that causes slappage. Or do they have a peroneal nerve entrapment at the fibular head? So let's talk about just a few more entrapments of this, and then I'll be done with this observation section. So if there's sciatic nerve damage, how would I know the difference between sciatic damage and lower root lesions? The glutes are preserved because the glutes are innervated by the lower sacral nerve roots, but they go through gluteal nerves. They don't go through the sciatic nerve. So the back of the leg will be gone and the hamstring, and then everything from the knee down is gone. The only thing preserved is this. So they can lift their leg up this way, but then everything else is floppy. Whereas if it's a sacral, lower sacral root lesion, you may now have weakness in the glute, weakness in S1 innervated muscles, but then the L5 is intact, so they'll probably be able to dorsi move the foot, dorsiflex. So we go through that and we're like, okay, is it sciatic nerve or is it lower sacral root? And then the sciatic nerve splits into the perineal and the tibial. And the perineal gets all of these muscles on the outside of the leg, the front of the leg, and then down to some of the muscels on the foot, especially the ones more lateral like the extensor digitorum brevis. So can you lift up your toes? Can you lift up your foot? And can you evert your foot? So if this is my foot, can I do this? Toes up and evert. Tibial is, can I push down and invert and curl my toes? So you can start to distinguish, okay, it's not sciatic nerve. Maybe it's the peroneal nerve. Is it peroneal nerve or is it tibial nerve? And the sensory distribution of the peroneal nerve is on the top of the foot. The sensory distribution for the tibial nerve is on the bottom of the foot. There's medial and lateral plantar and a calcaneal branch. For the peroneal, on the top, there's a deep and a superficial branch. The peroneal nerve can be entrapped in two. There's two big nerves. Each one have two entrapment places. For the peroneal nerve, it's the anterior tarsal tunnel on the top of the foot, and then the fibular head. For the tibial nerve, it's the posterior tarsal tunnel, and then very, very, very unusually in the popliteal fossa. So, we've looked at gait, we've looked at muscle tone of the legs, we've talked about sensory distributions of the cutaneous nerves, sensory distributions of the nerve roots, we've talked about proximal versus distal as it pertains to muscle disease, ventral horn cell disease, nerve root damage, cutaneous damage, and so forth. The sensory progression for if it's at the wrist, the elbow, or further up. And then just finally, polyneuropathies that are sensory more than they are motor, which is the vast majority of polyneuropathic diseases like diabetes or even thyroid or something else that can create a polyneuropathy. They usually start in the toes, progress their way up to like a sock. By the time it gets midway up to the shin, it started in the fingers, and then it will progress up into a glove. You can get any of your sensory testing equipment and just run it up, and right at the distribution, they'll be like, I can't feel it that good, I can't feel it, okay, now I can feel it good. And in men, a lot of times where the sock distribution is, people will start to lose normal hair growth right at that level. So we always, and I'll show you this in a different practicum here in a second, we measure small versus large diameter fibers. Small is pain and temperature. And then the larger fibers are more light touch vibration types of things. So we test both fiber types because we can have a polyneuropathy that's small fiber and a polyneuropathy that is large fiber, or both. And most polyneuropathies start out as sensory years before motor, unless it's hereditary or vascular or a lot of times autoimmune like CIDP or AIDP like Guillain-Barré. So now we've learned to observe a patient. Learn how to quickly observe their gait, their face, their posture, muscle tone, posturing with an arm, posturing with a leg. Do they have loss in any distribution? Do they have any goiters? Do you see pulsations? Do you see thrills, heaves? Are they having to breathe with accessory muscles? Are their nostrils flaring when they breathe? That could be a sign of respiratory distress. See if they're barrel-chested. See if they're blue. See if they're pale. See if they're red. See if they're cyanotic, where the lips are blue. See if they have a tremor, a twitch. See if they have any growths on their skin, like a mole. If they have any plaquing, like psoriasis. If they have anything like eczema. You look at those things, and now you just did a very, very good, not only functional neurological examination, but also for functional medicine or even general practice. You did a good observation. Okay? Now I know most of you didn't get that just by listening, but it's recorded. That's it.